Chapter 38, Headaches. We have tension and migraine headaches under headaches. For tension headaches, the first line of therapy is Tylenol or aspirins. Second is NSAIDs. Third is barbiturates. For prevention, we use TCAs. Tension headaches. First line treatment is acetaminophen, which inhibits the brain's prostaglandin synthesis, or aspirins. For acetaminophen, there's potential for hepatotoxicity, which would include nausea, vomiting, headache. Minimal dosing intervals are 4 hours. Maximum dose in adults is 50 kilograms and over. 4,000 milligrams per day in divided doses, which is every 4 to 6 hours. This is a pregnancy category C. Potential for GI side effects in aspirin, and you would avoid using aspirin in children 16 years and under with viral infections due to risk for Rye syndrome. Second line therapy is NSAIDs, which includes ibuprofen, naproxen, and ketoprofen. This inhibits the prostaglandin synthesis by decreasing the activity of the COX enzyme 1 and 2, which results in decreased formation of the prostaglandin precursor associated with inflammation and pain. Adverse reactions that are common: nausea, gastritis, diarrhea, abdominal cramps, GI ulcers, peripheral edema, hypertension, severe and important GI proliferation or perforation and bleeding, renal toxicity, bronchoconstriction, asthma, rash, tinnitus, hearing loss. Major drug-to-drug interaction is corticosteroids. They increase the GI side effects. Ethanol increases the GI irritation. And many ACE, ARBs, anticoagulants, antiplatelets, and beta blockers and digoxin all have major drug-to-drug interactions. Black box warnings for NSAIDs. They increase the risk for cardiovascular risks because they decrease the sodium excretion. Increase risk for thrombosis, stroke, and MI except for aspirin. Use with caution in patients with heart failure, renal insufficiency, and hypertension. Third line treatment is butalbital containing compounds. First one would be Furoset, which is acetaminophen, butalbital, and caffeine. Second is Furanol, which is aspirin, butalbital, and caffeine. This is a Schedule 3 drug. The only difference between the Schedule 3 Furanol and the not Schedule 3 Furoset is Furoset has aspirin and Furanol has Furoset has acetaminophen and Furanol has aspirin. Remember, once again, Furoset has acetaminophen, Tylenol. Furanol has aspirin. Adverse reaction is dizziness, drowsiness, nausea, respiratory and CNS depression. Caution with patients that they should not use other CNS depressants, including alcohol, and to avoid use of over-the-counter medications that also contain acetaminophen at the same time. With the Furoset. This is to avoid hepatic injury. Tension headaches. For prevention, the tricyclic antidepressants or TCAs. They block the synaptic reuptake of the serotonin and norepinephrine and increase the concentration in the CNS synapses. Side effects are anticholinergic, dry mouth, constipation, urinary hesitancy, and blurred vision, orthostatic hypotension, and sedation. Medication under this class is the amitriptyline, Elavil. Its low dose is a gold standard for first-line treatment of preventing headaches. Anti-nociceptive effects are independent of the antidepressant effects. They may increase the dose when treating for depression as well. Used with patients who experience 2 or more headache episodes per week. The black box warning for this medication is potential for suicide ideation, especially in adolescents and young adults. Avoid with other drugs that increase the serotonin level. Do not use within 14 days of MAOI inhibitors. Do not use with patients that have had recent MI. When you give to elderly patients, start at half the normal dose and titrate up slowly. The goals of the therapy is to reduce the severity and the frequency of headaches, thereby improving the patient's quality of life and the ability to function. Select appropriate analgesic agents that will have the fewest side effects. Consider prophylactic therapy in addition to the abortive analgesic agents for patients who have 2 significant headaches per week. Something to consider is medication overuse headaches. These are headaches that are caused from patients who take medication for tension headaches or migraine headaches more than 2 times per week. They are at risk for chronic daily headaches and medication overuse headaches. Migraine headaches. Migraine headaches, we have the lines of therapy of 1, NSAIDs with aspirins or aspirins, and 2, 5-HT triptans. For prevention, there's beta blockers and TCAs. First line treatment, NSAIDs or aspirins. As discussed previously, NSAIDs inhibit the prostaglandin synthesis by decreasing the activity of the COX enzyme 1 and 2, which results in decreased formation of the prostaglandin precursor associated with inflammation and pain. Adverse reactions, common nausea, gastritis, diarrhea, abdominal cramps, GI ulcers, peripheral edema, hypertension, severe and important GI perforation and bleeding, renal toxicity, bronchoconstriction, asthma, rash, tinnitus, hearing loss. Drug-to-drug interactions, corticosteroids, ethanol, many ACEs and ARBs, anticoagulants, antiplatelets, beta blockers, and digoxin. Black box warning is the increased cardiovascular risk because it decreases the sodium excretion. Risk for thrombosis, stroke, and MI except for aspirin. Use with caution in patients with heart failure, renal insufficiency, and hypertension. Second line treatment for abortive migraines, the 5-HT receptor agonists or the triptans. The indication is for acute management of the migraine headaches. This acts on the extracerebral and intracerebral blood vessels, resulting in vasoconstriction and the decreased trigeminal nerve transmission. They must be avoided in patients with concurrent cardiovascular disease such as CVAs, TIAs, and uncontrolled hypertension. Sumatriptan is the first prototype for this drug class. Adverse reactions are common. The common ones are flushing, chest discomfort, vertigo, and paresthesia. Adverse reactions that are rare but serious: coronary vasospasms, MI, arrhythmias, seizure, hypertensive crisis. So first tier of the second line treatment for triptans. First tier to the second line treatment of triptans is the sumatriptan, which was mentioned previously. It has a shorter half-life, so a second dose may be required if the headache returns. Naratriptan Emerge is a slower onset. It takes 1 to 2 hours. This is a good choice for patients experiencing recurrent headaches or chest tightness when using sumatriptan. Always administer the first dose under direct supervision. Need to monitor for any signs and symptoms of cardiovascular disease. No effect when administered for patients that are experiencing the aura prior to a migraine onset, which means that if the aura has already occurred, you cannot use this medication to prevent a migraine. The migraine process has already started. Migraine prevention, beta-adrenergic blockers or beta blockers. Beta-adrenergic antagonists block the response to the beta-adrenergic stimulation at the receptor level, reducing the heart rate, blood pressure, and myocardial oxygen demand. Propranolol and timolol are used for the migraine prevention. Adverse reactions that are common: bradycardia, sexual dysfunction, hypotension, fatigue, lethargy. Adverse reactions that are rare but serious: heart block, worsening heart failure, bronchoconstriction in non-selective agents, and depression. May mask the adrenergic-related symptoms of hypoglycemia in patients with insulin or oral hypoglycemic agents. Propranolol and Inderal is the non-selective medication within this class. The black box warning is avoid abrupt withdrawal. Do not withdraw abruptly due to the risk for rebound or acute tachycardia, hypertension, and or ischemia. The tricyclic antidepressants, the amitriptyline, which was previously discussed, but they block the presynaptic reuptake of the serotonin norepinephrine, thereby increasing the concentration of these CNS neurotransmitters within the synapses. You can get the orthostatic hypotension. This would lead patients to be on a fall precaution. Sedation is common and decreases with the continued treatment. Anticholinergic side effects are major drawbacks: the dry mouth, constipation, urinary hesitancy, blurred vision, and in some cases mental confusion. The goals of therapy within this treatment is prevention or relief of pain and symptoms, improve patients' quality of life, and minimize the side effects. There are some considerations for the pediatric population. Migraines are the most common headache in children. Severe nausea and vomiting is more likely to occur. Manage with acetaminophen, ibuprofen, and antiemetics. Triptans are not indicated for use in children. Amitriptyline may be used for prevention when indicated. Pregnancy risk needs to be considered when prescribing medication. Geriatric population for most of the medications within this test can be contraindicated, and in some cases dosing needs to be reduced and titrated up slowly. Chapter 40, Major Depressive Disorder. Lines of therapy are SSRIs or SNRIs. Second would be TCAs. Third would be atypical antidepressants. First line treatment is the SSRI or SSNI. The SSRI is the select serotonin reuptake inhibitors, citalopram, fluoxetine, paroxetine, sertraline. That's Celexa, Prozac, Paxil, and Zoloft. The action of these drugs are to block the synaptic reuptake of serotonin by increasing the concentration of this CNS neurotransmitter in the synapses. Serotonin and norepinephrine reuptake inhibitors, duloxetine, Cymbalta, venlafaxine, Effexor. They block the neural reuptake of serotonin and norepinephrine. Common side effects, GI side effects, and increased blood pressure. Fewer sexual side effects than the SSRIs. Therapeutic benefit may require several weeks, 6 to 12 weeks, before benefit is seen. You would need to educate the patient on serotonin toxicity, excessive serotonin levels, which could be presented as sweating, tremors, increased heart rate. There is risk for seizure, among other symptoms. Black box warning for the first line treatment is antidepressants may increase suicidal ideation. Do not use within 14 days of MAOI therapies. Do not use with over-the-counter herbals such as SAMI and St. John wort. Second line treatment for major depressive disorder is TCAs, which is unfavorable due to the side effects. Amitriptyline, they typically increase the amount of the neurotransmitters within the synaptic gap. They block the presynaptic reuptake of the serotonin and norepinephrine, thereby increasing the concentration of these CNS neurotransmitters in the synapses. Once again, there's orthostatic hypotension, which may occur. You need to counsel the patient on fall precautions. Sedation is common and decreases with continued treatment. Anticholinergic side effects are a major drawback. Dry mouth, constipation, urinary hesitancy, blurred vision, and mental confusion can occur. When using this medication for anxiety, it would be the imipramine or tofranil. Third line treatment, atypical antidepressants or TCAs based on the past response. Bupropion or Wellbutrin. This one also has multiple mechanisms of action, typically increasing the amount of neurotransmitters within the synaptic gap. They require several weeks of therapy to get to the full effect. Black box warning, once again, is suicide risk and ideation in children, adolescents, and young adults. It is a major substrate of the CYP2B6 and strong inhibitor of the CYP2D6. Do not use concomitantly with St. John's wort or similar herbs used for depression. Common side effects is dry mouth. Insomnia may diminish over time, particularly useful for patients suffering from sexual side effects or excessive sedation from other agents. Do not use within 14 days of MAOIs. When monitoring these patients, we would consider the acute treatment phase, which can take 6 to 12 weeks for the full therapeutic response. And we would be checking for to make sure the patient is taking the medication as prescribed. Continual phase begins when the goals are met at the acute phase and can take 9 months to 1 year. It is important to continue antidepressant therapy for 4 to 6 months after full symptoms resolution. This will reduce the risk of relapse. If the patient is demonstrating good response to treatment but still experiences symptoms, increase dose of antidepressant. If patient is demonstrating inadequate response to treatment, consider selecting a different drug with the same class or different class. Consult patient on the signs and symptoms of serotonin toxicity, which includes agitation, restlessness, diaphoresis, tachycardia, hyperthermia, nausea, and vomiting. Additional medications are the MAOI inhibitors. Antidepressant agent can block the MAOI enzyme, inhibits the reuptake of the neurotransmitter, agonize or antagonize an associated receptor, and in fact the mechanism increases the available concentration of the neurotransmitters. Next treatment is for anxiety disorders, or we will start with the first line of therapy in a general anxiety disorder, SSRIs or SNRIs. 2 would be a short course of the benzos. 3 would be CBT proven to be greater treatment than the TCAs or buspirone. Major drug classes used to treat anxiety disorders: the SSRIs and SNRIs and the TCAs. The new medication discussed within this system or this section is the benzodiazepines, the alprazolam, Xanax, clonazepam, Klonopin, diazepam, Valium, lorazepam, Ativan. MAOIs, which inhibit the action of the natural enzyme system, the monoamine oxidase that breaks down the serotonin, epinephrine, and dopamine. They are infrequently prescribed now, and they have unfavorable side effects and the risk of hypertensive crisis within the sympathetic substrates, caffeine, and foods with tyramine. Drugs within that category, the MAOIs is Celagene, MSAM, isocarboxide, Marplam, phenelazine, Nardil, tranylcypromine pronate. Drug and food interactions. Risk of hypertensive crisis is increased with ingestion of foods containing higher levels of tyramine, an amino acid that regulates blood pressure. Examples include aged cheese, sauerkraut, cured meats, draft beer, and fermented soy products, like tofu. The non-benzodiazepines, azaprolone and buspirone. Now for generalized anxiety disorder, GAD. The first line treatment is the SSRIs or the SNRIs. SSRIs, citalopram, fluoxetine, paroxetine, sertraline. Actions block the presynaptic reuptake of serotonin by increasing the concentration of the CNS neurotransmitter. SNRIs duloxetine, Cymbalta, venlafaxine, Effexor. They block the neural reuptake of serotonin and norepinephrine. Common side effects is GI effect, increased blood pressure, fewer sexual side effects than the SSRIs. Therapeutic benefit may take several weeks prior to seeing full benefit. Educate patient on serotonin toxicity, sweating, tremors, heart rate. Black box warning, like other antidepressants, increased suicide ideation. Do not use within 14 days of MAOI therapy, and do not use with over-the-counter medication herbals like SAMI and St. John wort. Short course of benzodiazepine may be used for symptom relief in an interim while the SSRI and SNRI reaches the therapeutic level. Antidepressants, SSRIs, SNRIs, TCAs, benzodiazepines, MAOI inhibitors, non-benzodiazepines, the allopurinol, azapirone. Second-line therapy, try another SSRI or buspirone. They can take 1 to 2 weeks for full effect. Third line is a TCA alone or buspirone. The goals of drug therapy is remission, complete resolution of anxiety symptoms, return to pre-morbid functionality and quality of life. The ideal anxiolytic medication should be promoting calmness without resulting in daytime sedation and drowsiness, and without producing physical or psychological dependence. Next is panic disorder. Treatment is CBT or SSRIs or SNRIs. First treatment is non-pharmacologic CBT, SSRI or SNRIs. Benzodiazepines can be used for short-term interim therapy, while the SSRI and the SNRI reaches therapeutic level. Alprazolam, Xanax, is the only benzodiazepine approved by the FDA for panic disorder. Remember, alprazolam, Xanax, is the only benzodiazepine approved for FDA use for panic disorder. Second-line therapy is a different SSRI or venlafaxine. Venlafaxine is the SNRI. Next, Chapter 42, Insomnia and Sleep Disorders. Sleep insomnia. First step is sleep hygiene. Second is a benzo or benzoreceptor agonist. Third is a benzoreceptor agonist or sedative antidepressant. Benzodiazepine, alprazolam, Xanax, flurazepam, Delamine, lorazepam, Ativan, temazepam, Restoril. Benzodiazepine receptor agonists. Ezapicolone, Lunesta, zolpidem, Ambien, zolepton, sonata. Orexin receptor agonist has sulfur, SUVRO, Rexent. Belsomra.
Here's what I found on Wikipedia. A soundbar.
First line treatment for insomnia, which is sleep hygiene. First line treatment for insomnia that is pharmacological. Benzodiazepines and benzodiazepine receptor agonists, and first generation antihistamines. This facilitates the activity of the GABA. Most are scheduled for and should be used for a limited duration. Serious CNS sedation when combined with alcohol to be avoided. Do not discontinue abruptly. Taper. Only use for the shortest duration possible. Failed response to insomnia treatment after 7 to 10 days is a red flag, potential psychiatric or medical disorders. Second line treatment is alternating to a short-acting benzoprine receptor agonist with Ramelton, a sedating antidepressant, trazodone, or amitriptyline. Diagnostic criteria for restless leg syndrome, Willis-Ekbom. We have lines of therapy is dopaminergic agents, Ropinirole, pramipexole, and rotagadolene, Tramzoderm. So we've got Requip, Mirapex, and the retagaltine. The anticonvulsant alpha-2 delta ligands, gabapentin, and Carbil. Horizont. Next, we have hypertension. Secondary cause for hypertension is chronic kidney disease, anemia, low GFR, small kidney, renovascular hypertension, abdominal bruits, elevated plasma renin activity, increased 30%